about anal cancers. Now, the whole thing about anal cancers is that to manage anal cancers, you need to know the terminology. It's just a little important because we're talking about anal sphincter a lot. Well, the most important thing is to know the anatomy, and if you can look here, the dentate line, the dentate line is the middle part of the anal canal or the anal canal. Anus is the anal canal, okay? And in the anal canal, above the anal canal is the rectum. Now, the anal, here is the levator ani muscle. Well, the reason I'm telling you this is because if you understand this anatomy, it's easy. Above the dentate line would be portal drainage, and below the dentate line would be systemic drainage. We look at that in the lymph node part. But right now, you need to know that anal canal is different from perianal because the main goal is sphincter preservation, and because of that, we don't do surgery anymore for anal canal cancers. But so if you look here, C is a tumor over here which will grow here in the lower anal canal, or A is a growth in the upper anal canal, or B is a growth in the both parts of the anal canal. Here you can see the internal sphincter muscle and the external sphincter muscle and internal sphincter muscle. These are the muscles which cause, the sphincter for the anal canal. So now, with that clear, you need to understand that C, anal canal cancer will never be operated because when we do surgery, it leads to incontinence, and then incontinence when you have APR used to be done, abdominal perineal dissection. Now it's not done anymore. And D is perianal. Now this is at least 1 centimeter away from the anal canal, and this pigmented line over here, at least 1 centimeter away from that, would be called perianal. Now, E would be just called a skin cancer, not an anal canal cancer. So, if you understand this difference, you'll understand the guidelines. Uh, Now, just to note that the dentate line is here, and below the dentate line, we usually have a training inguinal nodes, and above the dentate line, you could have it training into the internal iliac nodes, superior rectal nodes, or external iliac nodes. Now that. And what is the TNM staging of anal canal? Is TIS is carcinoma in situ. T1 is less than 2 centimeters. So this is like head and neck almost, where 2 to 4 is head and neck, 2 to 5 is in breast. But T2 is 2 to 5, 3 greater than 5, and T4 is invading nearby organs. Now with that detour, let's get back to the esmo guidelines for management of diagnosis, management, and treatment. Now, anal canal is squamous cell usually, and HPV infection is seen in about 80 to 85% of the patients. Diagnosis would be by biopsy. When there's bleeding, anorectal analysis, you can do HPV testing. And then the best way to stage anal canal cancers is to do MRI. The local staging would be an MRI, which would see T1 and T2, and then plan the sphincter distance calculation. And then you have a planning RT thing for anal canal cancers. Now, as mentioned, no anal canal cancer that's involving the sphincter would be recommended to go in for surgery. Therefore, you can see anal margin cancer stage 1, T1 only would be recommended for local excision. But what if it is stage 2 and 3 anal margin cancer that would have like either if there's a lymph node involved in the anal margin, or if you have So if it's T2, that would be like involvement of the muscular layer. T3, T4, penetration of the anal margin or the anal cancer. The answer would always be treatment would be definitive CTRT. Cure the cancer, RT at a dose of greater than 50 grays. And you will give dual chemosensitizers, 5-FU and MMC, mitomycin C. Sometimes you can replace 5-FU with capecitabine. And then you if it is an anal margin, as we said, where it's not involving the sphincter, you can do a wide local excision. Otherwise, we don't do surgery anymore. But then we do a follow up, and this follow up duration is very important because this any cancers take a long time to respond, and it can take up to 26 weeks to respond. So the response, uh, it takes a long time. So you have the patient, you give CTRT to the lesion, and then the lesion doesn't disappear. It takes like after 12 weeks, when they do it after 8 to 12 weeks, when they repeat a biopsy, you know, uh, they don't recommend repeating biopsies because it may confound the pathological interpretation because it takes very long. And you know, so in 26 weeks, that's the optimal time. 26 for up to 6 months, almost 6 months is when we will do a repeat biopsy. Then there will be pathological complete response. Well, majority of tumors that persist, you know, are recovered. They do so within the first 24 months after completing CTRT. Well, if there's local recurrence of growth, you can't do CTRT again. So, if there's local recurrence of growth, do an MDT, then go to advanced management. And so anal margin cancers, as discussed, we do a wide local excision only if it's close to the margin. Stage 4, first line chemo packet carbo can check PDL1 where people have progressed. As in colon in rectal cancers, which we'll discuss later. You divide it to left and right, which you will manage differently. But here, give Paticarbo, TPF, PDL1 may be considered. There's still a lot of trials going on. Well, anal cancer is seen a lot in people that are involved in anal sex, in gay people who have repeated anal sex. So, in in those patients, you could screen them, but the most important thing is to do HIV test in anyone that has anal cancer and P16 assessment for suspicious anal cancer. As P16 is bigger of HPV, and check HPV. Well, that covers anal cancer for you.